Welcome back guys. Now in this video let's discuss about movement disorders, which includes Parkinsonism, Huntington's disease, Wilson's disease where there is hepatolenticular degeneration. Okay, so we'll discuss about the movement disorders. Let's begin. Movement disorders. Now in this video I will be mainly concentrating on Parkinsonism, so what exactly is Parkinsonism? It's pathophysiology, okay, etiology, pathophysiology, and also the treatment, especially, which is important for the exams. I will be concentrating on Parkinsonism, followed by Huntington's disease. Okay, so you can ask me why I am going to discuss about the Parkinsonism, because in Parkinsonism I hope you already know that there is damage to the midbrain structures like substantia and nigra. The patient is going to have tremors, bradykinesia, akinesia. It's a movement related problems. So the patient is going to have cogwheel rigidity, like a pill rolling tremors are going to be seen, resting tremors are going to be seen. So as it's a movement disorder, we will be discussing Parkinsonism under this topic. Huntington's, you already know there will be Huntington's chorea. Okay, Huntington's chorea, involuntary movements are going to be seen. So Huntington's followed by hemibalismus, okay, Wilson's disease. Now in order to understand these four disorders, first you should know what is a basal ganglia. Okay, why? Because all these conditions, okay, in all these conditions there is damage to the basal ganglia. Okay, so damage to the structures in the basal ganglia is the one which is going to cause these movement disorders. So first let's discuss about what exactly is basal ganglia, what is its functions, what are the components of the basal ganglia, and which structures are getting damaged in basal ganglia leading to the following conditions. Okay, so now let's begin. Say this is the cross section of the brain. Okay, you know it, this is the cross section of the brain like this is the coronal section. Now in the coronal section you can very clearly see these are the ventricles. Okay, these two dots which I am highlighting over here, these are the ventricles, the first and the second ventricle. Now just side to the ventricles, are you able to appreciate there is a structure present, this grey matter structure, this is called as the caudate nucleus. Okay, now down to this caudate nucleus, here is the thalamus. These two bodies which I am pointing right now, these bodies are called as the thalamus. Now side to the thalamus, this structure, this big piece of grey matter which I am highlighting, it is called as a putamen. Okay, putamen, sir. Now these structures which I am highlighting right now, this structure is called as a globus pallidus, which includes two parts, globus pallidus internus and globus pallidus externus. Okay, and also there are subthalamic nuclei. Okay, subthalamic nuclei is there, substantia nigra is going to be there. So these are all the components of the basal ganglia. So what are the components of the basal ganglia? Let me write one by one. So components. Okay, the components, there are 5 structures present. What are these 5 structures? Number 1, caudate nucleus. Okay, caudate nucleus followed by putamen, globus pallidus, fourth subthalamic nucleus, and the last one is substantia nigra in the midbrain. Okay, substantia nigra in the midbrain. See, this is very much important for your exams. The caudate nucleus, okay, the caudate nucleus and putamen, these two structures together is called as striatum. Okay, it's called as the striatum. Okay, these two structures together. What are these two structures? This caudate nucleus and this putamen, these two structures together, they are called as the striatum, and the striatum is considered as the input to the basal ganglia. Okay, it's going to take the information. It's like it's acting like an input It receives the information from the cortex. Okay, and this striatum is going to produce which neurotransmitters? GABA. Okay, GABA is going to be produced. Next, globus pallidus, it consists of two structures again, that is the GPI globus pallidus internus and globus pallidus externus. Globus pallidus internus and globus pallidus externus. Okay, two structures are there. Again, let me show you. See, this is the globus pallidus, which is having two structures, two part, internus and externus. Internus and externus. Okay. Now, guys, please look here. This is the globus pallidus, right, which I am highlighting right now. This is the globus pallidus, internus and externus, and this structure, which is the putamen. Now, all these three structures, how they are looking like? They are looking like a lens. So, this is called as the three structures together, or I should say the globus pallidus and the putamen. The globus pallidus and the putamen together is called as, see these two structures, the putamen and globus pallidus, together they are called as lentiform nucleus. Okay, don't confuse. It's not the globus pallidus internus and globus pallidus externus. No, not these two structures. It's the total globus pallidus and the putamen. Together, it's called as a lentiform nucleus, and even it releases GABA as a neurotransmitter. And the last fellow, not last, the before one, the subthalamic nucleus. See, the subthalamic nucleus is going to produce excitatory neurotransmitters like glutamate. Okay, it produces glutamate, which is an excitatory neurotransmitter, and the substantia nigra, which is present in the midbrain. Okay, the substantia nigra, it's actually looking like a pigmented area. It actually looks like a pigmented area because of the presence of the dopamine or the dopaminergic neurons. So, the substantia nigra, which is present in the midbrain, it releases what? Dopamine. Okay, it releases dopamine. So, dopaminergic neurons. So, these are the 5 components of the basal ganglia. I have shown you where they are located also. I have shown you where is the location and what are the neurotransmitters. Now, first question is, sir, what is the function of this basal ganglia? Basal ganglia ka function kya hai? What exactly the function of the basal ganglia? Okay. Now look, let me write here itself. The function of the basal ganglia is, actually there are two functions. One is stores and plans motor programs. Okay, stores and plans the motor programs. So for example, let me ask you, see a 5-year-old doesn't know how to balance a bicycle, okay, how to ride a bicycle. See, riding a bicycle is a motor program, okay, how to actually balance it, okay. So which muscle to contract, which muscle to relax, how to exactly balance the bicycle, it's a motor program, okay. So that motor program is not there for a 5-year-old, but adult person, he knows how to perform that movement, okay, how to perform that motor action. So those motor actions, those motor programs are stored in a part called as basal ganglia, okay. So basal ganglia is the one which stores and which executes a complex movement. For example, when you are 5 years old, do you know how to do chatting? Like that motor program, do you have that motor program? No, it's not there. But now you know how to do the chatting, or swimming, or somersaulting. These motor programs are stored in a part called as the basal ganglia. Okay. Next, when you are at rest, do you need any unnecessary movements? When you are absolutely at rest, do you require any movements? No, we don't want any unnecessary movements. So basal ganglia is the one which inhibits involuntary movements. Okay. See, when you are at rest, there is cerebral cortex is present. Okay, cerebral cortex is there. Upper motor neurons, lower motor neurons, neuromuscular junction, muscles are ready, but still muscles are not contracting. Though the entire apparatus is present, but still they are not contracting, because the basal ganglia will inhibit unnecessary movements. Whenever you want it, then only there will be movement, otherwise no movements. So prevents involuntary movements. Okay, it prevents the involuntary movements or unnecessary movements, okay, to say. Next, first of all, let me show you the circuits. Okay, let me show you the circuits, how exactly movement occurs. Okay, how exactly movement occurs. So, let me write here the cortex. This is a simple schematic diagram. See, cortex is the one which is responsible for the movements. Okay, cortex, you need to activate the cortex. Okay, let's put it this way. You need to activate the cortex to execute the movements. Okay, so cortex activation is required. Who will activate the cortex? Thalamus. So thalamus is the one which should activate the cortex. So the cortex, once it is activated, it will activate the spinal cord and brainstem. Okay, it will activate spinal cord and brainstem structures. So that movement, desired movement will be possible. So it's a simple. Thalamus should have to activate the cortex. Then the cortex, from the cortex, upper motor neurons are activated. They will activate the lower motor neurons. Lower motor neurons are the ones which are responsible for the contraction of the muscles. Okay. But see, during rest, okay, during rest, I have said you, there is no involuntary movement. Unnecessary movements are not there. So what exactly is happening? See, during rest, what happens is, you should know the structure. See, there is something called as a striatum. So you know what exactly is striatum? Striatum is made up of caudate and putamen. So striatum, what it is doing? So striatum have connections with the globus pallidus. So the globus pallidus is having two more structures, that is globus pallidus externus and globus pallidus internus. Globus pallidus externus and globus pallidus internus. Okay, there is a connection between striatum and globus pallidus. Okay, and here let me draw one more structure. Okay, look here. On this side I am drawing the substantia nigra. So substantia nigra is having how many parts? Two parts. Substantia nigra, pars compacta and substantia nigra, pars reticularis. Okay, the whole topic, though I am discussing it under pathology, but actually this is a topic of neuroanatomy. Okay, but for easy understanding purpose I am explaining it here. Okay, so substantia nigra, pars reticularis. See, what happens normally, sir? See, normally when you are at rest, there is no movements. Why there are no movements? Because you should understand, sir, from here, okay, I have to add one more structure here, that is subthalamic nucleus. Subthalamic nucleus. One more structure is there. So what happens normally is, this substantia nigra, pars reticularis, okay, this area, the substantia nigra, pars reticularis and globus pallidus internus, these two structures continuously, there it is what? GABA. Okay, so GABA is being released. Now this GABA, do you know what it will do? The GABA, it will come here and directly the GABAergic neurons are inhibiting the thalamus. Okay, what I am telling you, sir, constantly at rest. Okay, when you are at rest, the substantia nigra, pars reticularis area and the globus pallidus internus, GPI and substantia nigra, pars reticularis, what they are releasing? They are always releasing the GABA. Now what this GABA is doing? GABA is inhibiting the thalamus. So when thalamus is inhibited, now do you think cortex is going to be activated? No, cortex is also inhibited. When cortex is inhibited, do you think that spinal cord is going to be activated? No, spinal cord is also under inhibition. So do you think any movements are going to be possible? No movements. Movements are not possible. But when you wish to have a movement, for example, now you are having a thought, sir. In your premotor cortex, now you are getting a thought. Okay, let me do this activity. For example, let me go and grab this glass. So now this is a motor planning, this is a motor activity. For this motor activity, for this complex motor action, you need to activate certain muscles and you need to inhibit certain muscles. Certain muscles need to be activated, for example, like flexors need to be activated and the extensors, extensors need to be activated and flexors need to be inhibited. Now when I am taking back, the flexors need to be activated and the extensors need to be inhibited. So for this complex movements, okay, for the complex movements, you need to have the basal ganglia. Okay, now the basal ganglia should be involved. Now the motor cortex, the premotor cortex will consult the basal ganglia, what to do, how to perform this complex movement. Now basal ganglia, what do you know what it will do? See, now for the first time the premotor cortex, okay, the premotor cortex, it is communicating. See, the premotor cortex is going to communicate with the striatum, this thought, okay, I want to do with this movement. So cortex, what it is going to do? Cortex is going to release glutamate. Okay. Now striatum is activated. Now for the first time striatum is activated. The basal ganglia is activated. Now do you know what this striatum is going to do? Now this striatum, you know it, striatum is going to produce GABA. Okay, striatum is going to produce what? GABA. So GABA is the inhibitory neurotransmitter. Now this striatum is releasing the GABA. So GABA is an inhibitory neurotransmitter. Now what happens? This globus pallidus and substantia nigra pars reticulata, they are going to be inhibited. Now whenever they are inhibited, do you think GABA is going to be released from the structures? Now the GABA is not going to be released from the structures. Whenever the GABA is not getting released, okay, whenever the GABA is not getting released, now what happened to the thalamus? Now thalamus is not inhibited, now thalamus is getting activated. When thalamus is activated, cortex will be automatically activated. Okay, cortex will be automatically activated. Now this cortex is going to stimulate the spinal cord and the movement is going to be possible. Okay, and the movement is going to be executed. Whatever the muscles are required, those musculature is going to be contracting and the movement is going to be possible. Okay, so this is called as a direct pathway. Okay, this circuit is called as a direct pathway. Okay, now here I just want to add on a little booster. Okay, little booster for the direct pathway. What is that? See, the substantia nigra. Actually what happens is here, the substantia nigra pars compacta in the direct pathway, the substantia nigra pars compacta, okay, it's going to produce what? Dopamine. That dopamine is going to activate the striatum. Okay, dopamine, it will activate via the D1 receptors. Okay, via the D1 receptors, the dopamine, whatever coming from the substantia nigra pars compacta part, is going to stimulate the striatum. So striatum is going to be activated. Once the striatum is activated, what happens? I have explained you. Striatum is going to produce GABA. Now this GABA is going to inhibit the substantia nigra pars reticulata and globus pallidus internus is going to be inhibited. So there is no GABAergic inhibition of the thalamus. So thalamus is not inhibited, thalamus is activated, cortex is activated. Which cortex? Now the primary motor cortex. Now the primary motor cortex is going to be activated. So the primary motor cortex, the upper motor neurons of the primary motor cortex is going to be activated. Upper motor neurons activate the lower motor neurons in the spinal cord. Lower motor neurons are going to cause the contraction of the specific musculature, whatever are required. So this is something normal. So at the end of the day, the point which I want you to know is, see, this dopamine is required. Okay, now this dopamine, let me highlight here the dopamine. Via the D1 receptors is going to activate the striatum. And dopamine is the one which is giving the booster. It's like a kickstart for the movements. Okay, it initiates the movement. Dopamine is responsible for the movements. Remember, always remember, dopamine helps in the movements. Whenever you lose the dopamine, the movements, initiation of the movements is going to be difficult. That's what happens in the Parkinsonism. So let me show you here itself. Where is the damage, sir? In Parkinsonism, in Parkinson's, the damage is at this level. Okay. So in Parkinson's, the substantia nigra is going to be damaged. Okay, so Parkinson's affect this area. Okay, let me put a small X so that it will be easy for you. So this area is going to be affected like this. Okay, so there is one more condition I have discussed. Like in this video, I am going to discuss about Parkinsonism, Huntington's, hemibalismus, and Wilson's disease. So where exactly there is damage in the Huntington's? In Huntington's chorea, if there is a Huntington's, if the patient is having Huntington's, he is going to have the chorea. So where exactly is the problem in the Huntington disease? Let me show you. Sir, Huntington's is going to damage striatum. Okay, so Huntington's is going to damage the striatum, especially which part of the striatum? Striatum includes two, putamen as well as caudate nucleus. Okay, actually caudate nucleus is going to be affected. Okay, caudate nucleus is going to be affected. So Huntington's, the area that is damaged in the basal ganglia is called as the striatum. Okay, striatum is damaged. Next, Wilson's disease. Which structures are affected in the Wilson's disease? Globus pallidus, damage to the globus pallidus as well as striatum. okay, as well as striatum, right. So globus pallidus is going to be affected as well as striatum are affected in the Wilson's disease. That's why, see, it's all concerned with the movements. This basal ganglia structure is concerned with the movements. So whenever there is damage with these structures, there will be abnormal movements, involuntary movements are going to occur. So in Wilson's disease, remember, two structures are affected, that is the one striatum is affected as well as the globus pallidus is going to be affected. And the last one, there is something called as a hemipallismus. Okay, there is something called as a hemipallismus. So in hemipallismus condition, which structure is affected? Subthalamic nucleus is affected. Okay, subthalamic nucleus is affected. See, the subthalamic nucleus, what it will do is, since the subthalamic nucleus is going to produce glutamate. Okay, subthalamic nucleus is going to produce glutamate and it's going to help in the indirect pathway. There is something called as the indirect pathway. See, once the subthalamic nucleus is activated, for example, say, subthalamic nucleus is activated, it is going to produce glutamate. Glutamate. Now, what is the function of the glutamate? Glutamate activates, is the excitatory neurotransmitter. So, once the subthalamic nucleus is activated by the striatum, okay, so striatum actually it's a little like complex thing. First, striatum activates the globus pallidus externus. Then the globus pallidus externus is going to activate the subthalamic nucleus. Now, the subthalamic nucleus is going to produce the glutamate. Now, what glutamate will do? Glutamate is going to excite, activate globus pallidus internus. Globus pallidus internus is activated. When globus pallidus internus is activated, globus pallidus internus is going to produce the GABA. GABA is going to inhibit the thalamus. So, whatever the muscles which we don't require for the complex movement, say for example, for this complex movement, flexors need to be inhibited. So those flexors will be inhibited because of the indirect pathway. This is subthalamic nucleus doing. So once the subthalamic nucleus is activated, the subthalamic nucleus activates the globus pallidus internus. Certain neurons in the globus pallidus internus, not the entire globus pallidus, certain neurons in the globus pallidus internus. The globus pallidus internus is going to inhibit the thalamus. So thalamus is inhibited, cortex is inhibited. So that part of cortex which is required for this particular musculature will be inhibited. So muscles are inhibited. Okay, so complex movements are going to be possible. So for every movement, certain muscles need to be inhibited, certain muscles need to be activated. So okay, via the direct and indirect pathway, okay, direct pathway is activation of muscles, indirect pathway is inhibition of the muscles, inhibition of the movements. Okay, so via both this complex direct and indirect pathway, basal ganglia is going to maintain the, are going to be responsible for the complex movements. Okay, so I have said you direct pathway, indirect pathway, the structures of the basal ganglia, okay, and their neurotransmitters. Now after this, let's begin with the topic of Parkinson's disease. So what exactly is the problem in the Parkinson's disease? See, it's a degenerative disease of substantia nigra. So damage, degeneration of the neurons, damage to substantia nigra. Now if I show you the midbrain, the cross section of the midbrain, okay, for example, imagine this is the posterior part, the tectum, the tectal part, the back part at the dorsal part of the midbrain. I am showing you here. See where you can see the colliculi, okay, the superior and inferior colliculus will be present. Now if you look, the midbrain is going to look like this, right? The midbrain is going to look like this. These are the peduncles. Okay. Now here there is a structure which is called as the substantia nigra. Let me draw it with the black color. Yeah, look here. Here will be the substantia nigra. Actually substantia nigra, this area is highly pigmented. It looks very black in color. So what you will have here, you will have dopamine secreting neurons, dopaminergic neurons in the substantia nigra. So this part of the midbrain, okay, this structure of the midbrain is going to be damaged. The substantia nigra is going to be damaged. Okay, so let's write one by one important points. So it's a damage to the substantia nigra. Now what happens because of this damage? So there is a decreased amount of dopamine, where in pars compacta. Okay, there is a decrease in the amount of dopamine in the pars compacta of the substantia nigra. So, whenever the dopamine is losing from this area, okay, if you see the gross morphology, okay, morphology after the death of these persons, when you do the autopsy and when you look at the midbrain, do you know what you will look? See, this area will become pale in color. Okay, this area is losing the dopamine. The dopamine is not getting produced here, right? So, this area will look pale in color. So, there is depigmentation. So, on autopsy, what you can say is depigmentation. Okay, so if you take the neurons from here, okay, the neurons are getting degenerated. So under the microscopy, okay, gross morphology, there is a depigmentation. Okay, under microscopy, what you will see? Under microscopy, in this degenerating neurons, you can see the inclusions. Those inclusions are called as Lewy bodies. Okay, inside the neurons, you will see Lewy bodies. Now these Lewy bodies are made up of what? These Lewy bodies are made up of something called as alpha-synuclein. So alpha-synuclein, okay, NuClein, okay. So alpha-synuclein, the Lewy bodies are made up of alpha-synuclein. That's why it's also called as synucleopathies. Okay, Parkinsonism is one of the condition which is coming under the synucleopathies, where there is a degeneration of the dopaminergic neurons in the substantia nigra pars compacta. Okay, now why this area is getting degenerated? Okay, why this part of the midbrain is getting degenerated? See, there is a chemical called as MPTP. MPTP. So what exactly is MPTP, sir? Methyl phenyl tetrahydropyridine. Tetrahydropyridine. So methyl phenyl tetrahydropyridine. See, this chemical, once it enters into your body, it's going to damage substantia nigra. It damages the substantia nigra. Okay, so once the substantia nigra is going to be damaged, that's going to cause Parkinsonism. Okay, actually it's a contaminant. Okay, so actually it's a contaminant of the opioid drugs. Previously, the opioid drugs are contaminated in the labs with this chemical which is called as MPTP. So those patients who consumes this MPTP, they have developed Parkinsonism. Okay, that's the one important point which I want you to know. So methyl phenyl tetrahydropyridine is the one which can lead to Parkinsonism. Okay, next, how the patient is going to present in your clinic? Clinical features. The clinical features are going to be seen especially in the older age groups. The classical presentation is going to be 60 years old male. 60 years male patient. Okay, 60 years old male patient. He is going to have three symptoms, a triad of symptoms. The triad, I just remember it like rat. Okay, mnemonic is rat. What is this rat? Rigidity. Okay, rigidity, especially which kind of rigidity? Cog wheel. The type of rigidity is called as a cog wheel rigidity. Okay, the cog wheel rigidity. So the patients, when you try to just flex their hands or wrist, so it's going to be rigid. Okay, it will be tough for you to just flex their wrist. It will be easy, then it will become tough. Then it will be easy, it will become tough. So it's like a cog wheel. Okay, cog wheel have those things, right? So it's like a cog wheel rigidity. Next, A stands for akinesia. Akinesia. So no movements, or sometimes even the patient can have bradykinesia. Akinesia or bradykinesia can be seen. Why akinesia, bradykinesia? Because I have said you, dopamine is required for the activation of the direct pathway. For the activation of the direct pathway, what do you require? It's a dopamine. In the basal ganglia circuit, here I have given dopamine is required for the activation of the striatum. Once the striatum is activated, striatum is going to inhibit the globus pallidus internus and substantia nigra pars reticulata. But here dopamine is not there. When dopamine is not there, the initiation of the movement is not going to occur. So that's why bradykinesia or akinesia, and these patients are going to have tremors. These patients are going to have the tremors. What kind of tremors? So these patients' tremors, they will use these classical words in the exam. These are resting tremors. Resting tremors, which means the tremors are always present. okay, even during rest. It's not that when the patient tries to initiate the movement, he is having tremor. No, it's not like that. It's not an intentional tremor. Intentional tremors are seen with the cerebellar lesions. We'll discuss about that. So this is a resting tremor. Always the patient, when for example the patient is like this, he's going to have the tremors. Okay, so these tremors are also called as a pill rolling tremors. Pill rolling tremors. Apart from this triad, okay, apart from this triad in Parkinsonism, what else can be seen? First, the patient is having, okay, rigidity, akinesia, bradykinesia, tremors are seen. If you look at these patients, okay, so because of no proper muscle contraction, see for facial expressions also, okay, whether the happiness, sad, dull, okay, anger, that will be reflected in the face, right? The facial expression by the contraction of the muscles. So these patients have problem with the contraction of the muscles because dopamine is not there. So these patients will have masked face, okay, mask-like faces, okay, mask faces. Next, when you look at this fellow, okay, 50-year-old guy or 60-year-old guy who is suffering with a Parkinsonism, if you ask this person to walk, he is going to have shuffling gait. He is going to like take his steps just very, very small steps, okay. So this is called a shuffling gait. Shuffling gait. So this is what's going to be seen. And if you look at this person, he's going to have this kind of posture, okay, not erect, something like this. He's going to have a posture like this, okay, bent like this. So this is called as stooped posture. So the patient is going to have bradykinesia, akinesia, difficulty in the difficulty in initiation of the movements. But with the time, with exercise, okay, the movements will get better. Okay, this is the keyword that they can mention in the question. They says that this guy who is 50-year-old, who is having all these clinical features, by doing exercise, his movement is getting better. Think about Parkinson's. Okay, so with exercise, movement gets better. Okay, this is a key point which I want you to know. So these are the clinical features that are going to be seen in a patient who is going to have the Parkinsonism. Now, what are the drugs used for the treatment of Parkinsonism? Okay, treatment. So this area is also very much important for your exam. Drugs. The first drug is L-dopa or carbidopa. So L-dopa or carbidopa is used for the treatment of Parkinsonism. Why? See, this L-dopa, okay, which I am using from outside, actually the L-dopa is also going to be produced in our body. See, what is L-dopa? Levodopa, okay, levodopa. See, this L-dopa, what happens? Once it enters into the body, it's converted to dopamine in the central nervous system. So in the central nervous system, this L-dopa will be converted into dopamine. So problem solved, right? The patient is having dopamine crisis. The dopamine is not enough for the initiation of the movements. Dopamine is not there. So you have simply given the L-dopa. This L-dopa enters into the body. L-dopa crosses the blood-brain barrier. Once it enters into the brain, in the brain the L-dopa will be converted into dopamine. So the dopamine is, we are keeping the dopamine back in its place. So something like that, okay. Next, what other drugs can be used? The other drugs which are used are entacapone, tolcapone, entacapone. So what are these tolcapone, entacapone? So these are COMT, okay. COMT, what exactly COMT? I will explain you, okay. COMT inhibitors. inhibitors. Now what exactly the COMT is going to do? COMT, it prevent the breakdown of L-dopa, okay. So prevents breakdown of L-dopa. So whatever the L-dopa that's there, that L-dopa will be kept on broken down, okay, with the help of this COMT, okay. So COMT breaks down the L-dopa. So what we have to do with the COMT? We have to inhibit the COMT. Who will inhibit the COMT? Tolcapone, entacapone. Okay, how exactly they will do, where exactly they will do, I will explain. So 2 drugs completed. The third drug is selagelin. Okay, selegiolin. So what exactly the selegiolin is going to do? It's also going to prevent dopamine breakdown. Dopamine breakdown. Next, bromocriptine, drugs like bromocriptine. So what this bromocriptine is going to do? Bromocriptine is a dopamine like drug. It's a dopamine agonist. See, selegiolin, what it is doing, it prevents the dopamine breakdown. Yes, the L-dopa is going into the body, L-dopa is entering into the central nervous system, L-dopa is getting converted into dopamine. But dopamine will be broken down with the help of monoamine oxidases, MAO inhibitor. There are things called as the MAO inhibitors. The MAO is going to break down the dopamine. So you have to prevent the breakdown of dopamine. You have to prevent the breakdown of dopamine. You have to inhibit the MAO inhibitor. Like, you have to inhibit the MAO. Okay, monoamine oxidases, especially MAO-B. So the selegiolin, it's a MAO-B inhibitor. MAO-B inhibitor. So by inhibiting MAO-B, it prevents the breakdown of dopamine. Okay, again I will explain you this, don't worry. So bromocriptine also completed. So bromocriptine, bromocriptine. So bromocriptine, it's a dopamine like drug, it's a dopamine agonist, it stimulates the dopamine receptors. Okay, just like dopamine. Okay, it can also stimulate the dopamine receptors, so it can be used in the treatment of Parkinsonism. Apart from bromocriptine, the other drugs are pramipexole and ropinirole. Okay, so pramipexole and ropinirole. What exactly they are going to do? They are also dopamine agonist. Okay. Both are dopamine agonists. So bromocriptine is a dopamine agonist as well as pramipexole and ropinirole are also the dopamine agonists. Then why I have written them separately? Because one is an ergot derivative. It's an ergot derivative. This is non-ergot. Okay, these are non-ergot derivatives. Okay, non-ergot dopaminergic agonists. Next, after this, benztropine and benztropine and trihexyphenidyl. Okay, trihexyphenidyl. Benztropine and trihexyphenidyl. So what exactly are these drugs? They are anti-muscarinic drugs. So why we are using anti-muscarinic drugs? Especially to treat the tremors, whatever the tremor component that is there in the Parkinsonism, to control the tremors. Which of the following drugs are used? The anti-muscarinic drugs like benztropine and trihexyphenidyl. Okay, trihexyphenidyl. And you can also use propranolol. That's a beta blocker. It's also going to be used to treat the tremor component, and amantadine. Okay, amantadine. So what exactly is amantadine? It's an antiviral drug, right? Most of you know it has an antiviral. Okay, so amantadine, it's also dopamine agonist. It's also antimuscarinic. Okay, antimuscarinic or anticholinergics. So here in a broad table or in one single place, I have explained all the different drugs which can be used in the treatment of Parkinsonism, which can be used to treat the Parkinsonism, like levodopa, carbidopa. You can use it, tolcapone, entacapone, selegiolin, bromocriptine, pramipexole, benztropine, propranolol, amantadine, all these drugs. See, the reason why I have given here is because in your exam you can get a question something like all of the following drugs can be used in the treatment of Parkinsonism, except that questions are like very highly likely to come up in your exam. So you should know this list. So after knowing this, let's begin with one by one drug. L-dopa. Okay, L-dopa and carbidopa. okay, L-dopa and carbidopa. So what this L-dopa is going to do, I have explained you. So this L-dopa, it crosses blood-brain barrier. Now in the brain, okay, in the brain, this L-dopa is going to be converted into dopamine. Okay, in the brain it's going to be converted into dopamine. Okay, so this is good. The L-dopa, it crosses the blood-brain barrier. So in the brain it is getting converted into the dopamine. Okay, with the help of an enzyme called as the dopa decarboxylase. So with the help of which enzyme? Dopa decarboxylase. Now there is a problem with this drug. Do you know what is the problem? See, this decarboxylation, whatever is happening, if it happens in the brain, okay, you have taken the L-dopa enters into the brain. In the brain, if decarboxylation happens, that okay, dopa will be converted to dopamine and dopamine will be used for the movements, that's okay. But there is something called as peripheral decarboxylase. Okay, let me write. Peripheral, the blood, peripheral decarboxylase. Now what this peripheral decarboxylase is going to do? In the peripheral sites itself, in the blood itself, the L-dopa will be converted into dopamine. So it was supposed to be converted into dopamine in the central nervous system. We want the dopamine in the central nervous system. But one problem with the L-dopa is the L-dopa will be converted into dopamine in the periphery itself. Okay, so very less L-dopa is reaching the central nervous system. Most of the L-dopa is getting converted into dopamine in the periphery itself. So what we have with the help of this peripheral decarboxylase. So what you have to do, you have to inhibit this peripheral decarboxylase. Who is going to do that job for you? Now it is going to be done by carbidopa. Okay, carbidopa. So carbidopa is going to inhibit peripheral decarboxylase. So this peripheral decarboxylation is not happening. Otherwise, do you know what happens? For example, you can ask me. See, if you simply give L-dopa, L-dopa will be converted into dopamine in the periphery. And do you know what this dopamine is going to do? Dopamine is a catecholamine. Okay, dopamine is a catecholamine. Now this catecholamine is going to act on the heart. It's going to cause tachycardia. Okay, it's going to cause tachycardia. Okay, heart side effects are going to be seen. Not only that, this dopamine is going to cause the nausea. By acting on the area postrema or the vomiting center, the chemoreceptor trigger zone, it's going to cause nausea and vomiting. Okay, so these are the problems. So that's why usually we give L-dopa in combination with, okay, L-dopa in combination with the carbidopa. So what is the mechanism of action of the carbidopa? Carbidopa is going to inhibit the peripheral decarboxylation. Peripheral decarboxylation is inhibited, so most of the L-dopa will be available for the central nervous system. Okay, now, okay, you are giving L-dopa and carbidopa. So what we have discussed, so L-dopa should be given along with carbidopa. Okay, but still some problems are there. So if you give L-dopa along with carbidopa, okay, peripheral decarboxylation is not happening, L-dopa is going to the central nervous system and dopamine is getting produced. But in the central nervous system, what you have done, you have increased the dopamine levels. Okay, if you have increased the dopamine levels. So this increase in dopamine is going to cause the side effects, central nervous system side effects. See, dopamine is a catecholamine, it makes you alert. Okay, it makes you alert. So because of so much dopamine, there can be anxiety sometimes. Okay, there can be anxiety and agitation. Okay, there can be agitation, like aggressive, and there can be insomnia. Okay, that is sleeplessness. So all these are the side effects because of the L-dopa. Okay, L-dopa increasing the dopamine in the central nervous system, and these are the side effects that you can say. And like previously, whenever the patient is on L-dopa, whenever he is taking the L-dopa, these patients are asked not to take the B complex tablets. Okay, so these patients should avoid. Okay, especially vitamin B6. Because vitamin B6 is a cofactor for the peripheral decarboxylase, so more like for the decarboxylations, for all the decarboxylation reactions, you require the B6, especially for the peripheral decarboxylases. So if you take vitamin B6, what happens? B6 is going to activate the peripheral decarboxylase, so L-dopa will be converted into dopamine in the periphery itself. So those patients who are on L-dopa should avoid taking the B6. Okay, B6 supplements, that is the pyridoxine. Okay, this is the point which I want you to know. Okay guys, now let's discuss about other drugs which are entacapone and tolcapone. So what exactly this entacapone and tolcapone are doing? See, first of all, these drugs are COMT inhibitors. So first of all, what exactly is the COMT? By inhibiting the COMT, how actually we can treat the Parkinsonism, we'll discuss one by one. See, imagine this is the blood-brain barrier. Okay, blood-brain barrier. Here is the brain. This is the periphery. That's the blood. For example, let's take as a blood. Periphery is the blood. Now, what is the drug that we are giving? We are giving L-dopa. L-dopa. And that L-dopa, what it's going to do? That L-dopa is going to cross the blood-brain barrier. It's going to come into the central nervous system. We are giving along with the carbidopa. That's okay. But this L-dopa, it is inhibited. It is converted. This L-dopa will be metabolized. It becomes inactive. So whenever this L-dopa is there, that will be broken down into inactive state or like useless products with the help of this COMT. So COMT both in the periphery as well as in the central nervous system. So the COMT is going to metabolize the levodopa. So what it is going to do? So COMT is inhibiting the levodopa. So levodopa is not available, dopamine is going to go down, okay, dopamine levels will go down, Parkinsonism. Okay, so what we have to do now? So we are not just supposed to give L-dopa along with carbidopa, but also we have to inhibit the COMT, we have to inhibit the COMT. Who is going to inhibit the COMT? Entacapone and tolcapone. Okay, so this entacapone, tolcapone are the drugs. Okay, these drugs, okay, they will inhibit, okay, these drugs will inhibit the COMT. But mainly which I want you to know, the one point which I want you to know is the tolcapone. Look, tolcapone, it inhibits both the COMT, peripheral COMT as well as the COMT in the central nervous system. Both peripheral and central COMT inhibitor, tolcapone. See, remember toll for total, both in the CNS as well as in the periphery. But this entacapone work only in the periphery, okay, not in the central nervous system. This entacapone, let me just erase here. Entacapone, it's a peripheral. Let me write. Acts only in periphery, which means it's a peripheral COMT inhibitor. Now, who is looking good? It looks like tolcapone is looking good because it works in both the places. In both the places, COMT is going to be inhibited, levodopa is going to be spared. So levodopa will enter into the central nervous system, levodopa will be converted into dopamine. It looks good. But the problem with the tolcapone is that it causes hepatotoxicity. Okay, it's a hepatotoxic drug. Liver damage is going to occur by using this drug, which is tolcapone. Okay. Now after this, the next drug that which I want to discuss here, two drugs completed. Levodopa completed, carbidopa completed, entacapone, tolcapone completed. Levodopa, carbidopa, they are nothing but the dopamine. Okay, levodopa will convert into the dopamine. And what about the tolcapone and entacapone? COMT inhibitors. The third drug that I am going to discuss is called as seligilin. So what exactly is this seligilin? It's a MAO inhibitor. Okay, especially MAO type B, MAO B inhibitor. Now I want to ask you, what exactly is MAO? See, COMT means, COMT here stands for catechol O-methyl transferase. Okay, catechol O-methyl transferase. Now here MAO stands for monoamine oxidases. It's going to break down. Okay, it's going to break down the dopamine. For example, there are two types of MAO, MAO A and MAO B. There are two types of MAO, MAO A and MAO B. MAO A is going to mainly break down. It's going to mainly break down the serotonin. Okay, serotonin. That's a 5-HT. Okay, 5-HT. MAO A is going to take care about the serotonin. It breaks down the serotonin. MAO-B is going to break down the dopamine. Normal in the body, this is something normal. Okay, so what is this MAO-B doing? MAO-B is going to reduce the dopamine level, it breaks down the dopamine. So dopamine levels are going down, but what do we require in Parkinsonism? We need to increase the dopamine. So this drug salicylic, it breaks down the dopamine. Okay, so we need to inhibit this MAO-B. So who is going to inhibit the MAO-B? Salicylic. MAO-B is inhibited by salicylic. So along with L-dopa, we are also going to use carbidopa. We can use, see this L-dopa is like a king. Along with we need to give the soldiers, that's the carbidopa, will give carbidopa, will give entacapone. Also we can use salicylic. What this L-dopa will do? L-dopa increases the dopamine levels, and the dopamine destruction, the destruction of the dopamine, the metabolism of the dopamine is inhibited by this salicylic. But there are certain side effects with this salicylic. What are the side effects? The side effects are nausea, vomiting, hypotension, daytime sleepiness, excessive daytime sleepiness. So if you use this drug, there are some side effects. The three side effects are nausea, vomiting is common for everything. Okay, nausea, vomiting, hypotension and daytime sleepiness. These are the three problems with the salicylic. Now, what else you should know is there is something called a serotonin syndrome. Serotonin syndrome. Okay. So, what exactly is the serotonin syndrome? Why serotonin syndrome will occur? See, whenever you use this drug, salicylic, okay, whenever you use this drug, salicylic, along with SSRI, okay, what is this SSRI? Selective serotonin receptor inhibitor. Okay, these are selective serotonin receptor inhibitors. So, this SSRI is going to increase. Okay, SSRIs are going to increase what? Serotonin. Okay, SSRI increases the serotonin levels, no doubt. Okay, MAO-B, what it will do? See, MAO-B increases the dopamine levels, no doubt, increase the dopamine levels, but also it increases the serotonin levels to an extent. It also increases the serotonin levels. Okay, so MAO-B inhibitors to a certain degree can also increase serotonin because they are belonging to the same family. MAO-A, MAO-B. MAO-A inhibits the serotonin, MAO-B inhibits the dopamine. But if you inhibit MAO-B, dopamine is going to elevate, no doubt, but also serotonin will be elevated. Serotonin is also monoamine, serotonin is also monoamine, dopamine is also monoamine. So, MAO-B increases serotonin, SSRI increases serotonin. So, when you give this MAO-B inhibitor, that's a salicylic, along with SSRI, the patient is going to have super high levels of serotonin. That serotonin is going to cause a serotonin syndrome. Okay. So, what are the features which are seen in the serotonin syndrome? So, the patient is going to have three features. One is fever, because of the high level, okay, of serotonin, the patient is going to have fever, confusion, along with myoclonus. Myoclonus is the twitch, okay, twitch of the muscles. Okay. So, these three things are going to be seen. Not only this, one more thing which I want you to know with the salicylic side effect. The patient is going to have cheese effect. So, what exactly is this cheese effect, sir, if you ask me? See, MAO-A inhibitors and MAO-B inhibitors. Look, MAO-A and MAO-B. What they will do? They will block. Okay, they will inhibit breakdown of a compound called as. They will block breakdown of tyramine. So, tyramine is not getting broken down now. So, now our patient, he is taking the salicylic, that is a MAO-B inhibitor. When he is taking salicylic, there is no breakdown of tyramine. So, what happened to tyramine levels? Tyramine levels increases. Okay, tyramine levels increases, sir. Okay. Now, when the tyramine levels are increasing, what happens? So, this tyramine is going to cause the hypertension. Okay. So, imagine now my patient is eating cheese. See, this cheese, it have this compound called as a tyramine. Okay, now for example, if I take cheese, nothing will happen in me because the cheese which is getting broken down will produce the tyramine, and the tyramine will be broken down with by this MAO A and MAO B. MAO A, MAO B inhibits the breaks down the tyramine. Now, when I take MAO B inhibitor like salicylin or MAO A inhibitor, the tyramine breakdown is not occurring. So, tyramine levels increases, that tyramine is going to cause the hypertensive crisis. Okay. So, where do you have tyramine rich foods? The tyramine rich foods are, one is cheese, cottage cheese. Next, you can have it in red wine. Okay. Meat. So, whoever is taking the MAO B inhibitors, they are asked not to eat these things. Okay, cheese, red wine, meat, these substances should be avoided. Otherwise, what happens? There can be a cheese effect. Okay, cheese hypertension can occur. Now, after this, let me just show you a summary. All the Parkinsonism drugs. Okay, all the Parkinson's drugs in one place. Now, let me put a blood-brain barrier. Imagine this is the blood-brain barrier. Now, what is the drug that I am going to give? The king drug. It's L-Dopa. Okay, I have given the L-Dopa. But what is the problem with the L-Dopa? Now, in the periphery itself, the L-Dopa is getting converted into dopamine. The periphery itself it is converting. So, what I have to do? I have to inhibit this peripheral conversion. Okay, this peripheral conversion need to be inhibited. And who is going to do that job for me? That job is done by carbidopa. Okay, carbidopa inhibits this peripheral decarboxylation. So, now what happens? This levodopa is going to enter into the central nervous system, L-dopa. Now, in the central nervous system, the L-dopa will be converted into dopamine. Okay, it will be converted into dopamine. But the one problem is, in the periphery, one problem which I want to add is, see there is something called as a COMT. Okay, now that catechol O methyl transferase, okay, COMT is there, right? Now in the periphery, the COMT, what it is trying to do? The COMT tries to break down this levodopa. Now what I have to do? I have to also inhibit this COMT. Who is going to inhibit the COMT? COMT inhibitors, tolcapone, entacapone. So, entacapone only in the periphery and tolcapone. Okay, done. This is completed. Now, look in the central nervous system. In the central nervous system also, this L-dopa will be broken down by COMT. Okay. Now, what we have to do in the central nervous system also, the COMT need to be inhibited. The COMT need to be inhibited. Who will do the job? Only tolcapone. Okay, only tolcapone. Done. Now, see, here in the central nervous system, there is one more fellow who is trying to break down the L-dopa. Who is trying to break down this L-dopa? Who is that, sir? It is MAO B. MAO B also is trying to break down this levodopa. Now, we have to inhibit what? This MAO B also. MAO B also need to be inhibited. Who will do the job for us? Salicylin. So, briefly here I have explained all these drugs. Okay, all these drugs which are used in the treatment of Parkinsonism. What are they? The first important drug is L-dopa. L-dopa can be used along with carbidopa. You can use tolcapone, entacapone to do what? To prevent the breakdown from the COMT. In the central nervous system also same. The COMT can be inhibited by tolcapone but not the entacapone. And you can also use MAO B inhibitors like salicylin to increase the level of dopamine in the central nervous system. So, with this we have completed the treatment for the Parkinsonism. We have done the treatment for the Parkinsonism. See, this is the medical therapy. There is also surgical therapy. Previously, in older days, there is surgical treatment that is done. Surgical treatment. What is the surgical therapy that is done? Is pallidotomy. It's a partial destruction, okay, partial destruction of the globus pallidus, okay. So pallidotomy can be done, and thalamotomy. So thalamotomy, which means in the name itself, there is a partial ablation of the thalamus. So pallidotomy and thalamotomy are the surgical treatments which are done for the Parkinsonism in the olden days. Now also it's being done, but not that common. It's done in older days. Okay. So these days what we are going with is something called as a deep brain stimulation. Okay, deep brain stimulation. Okay, where we are going to keep a stimulator, deep brain stimulator. It is going to suppress the neural activation. Unnecessary neural activation is going to be suppressed to treat the tremors. Okay, to treat the tremors. Okay, so these are the points which I want you to know in the Parkinsonism. With this, Parkinsonism is completed. In the next video, I will be continuing with the Huntington's and Wilson's disease. Huntington's, Wilson's and hemiplasmas will be discussed in the next video. Hope the video is helpful. Thank you.